I'm going to be talking about a randomized controlled trial of mentalization-based treatment versus structured clinical management for patients with comorbid borderline personality disorder and antisocial personality disorder. Some background about borderline personality disorder and antisocial personality disorder. They both have high comorbidity with other disorders. There are obviously differences between both BPD and ASPD, but there's also overlap, specifically in terms of impulsivity, unpredictability, difficulties with emotion regulation, difficulties controlling anger, and behavior that could appear to others as manipulative. I won't go through all differences for the sake of time, but one example is that people with BPD often have a negative self image, while those with ASPD often have an inflated self image. Both are also characterized by deficits or distortions of mentalization. So, if you remember, we learned about mentalizing before. It's the process of making sense of the self and others in terms of mental states like beliefs, thoughts, feelings, and desires. In BPD, people tend to mentalize, quote, normally, except related to attachment relationships when emotional arousal leads to inability to interpret mind states, especially in the context of fear of abandonment. And in ASPD, people tend to have a more general and a deeper impairment in mentalizing and deficits in recognition of emotions, social cognition, and ability to link mental states to behavior. Some studies also show that people with ASPD have deficits in perspective taking and reading others' mental states. I'll go in more into the specifics of mentalization-based treatment in a future slide, but the basic idea is that it aims to improve mentalizing. It's been shown to be effective for improving a number of clinically significant outcomes for people with BPD. And the mentalization model of antisocial behavior is important to understand. So the basic understanding here is that there's a dysfunction of the attachment system that then temporarily inhibits affect regulation and mentalizing abilities. And when people have mentalizing deficits, it can lead to volatile and aggressive behavior, especially during times of interpersonal stress. Aims of this study were to examine whether MBT could reduce symptoms related to antisocial behavior in patients with both BPD and ASPD when compared to patients receiving the other protocol, which was structured clinical management of similar intensity but excluding MBT components. They also wanted to test whether MBT is effective in reducing negative affect states like anxiety and depression. And they wanted to measure the change in the common consequences of aggression, like effects on quality of familial and social relationships and subjective well-being. So a little bit about the two treatments being studied. MBT is manualized and structured. It integrates cognitive, psychodynamic, and relational components based in attachment theory, focuses on improving mentalizing, and is 18 months of weekly and group therapy. Structured clinical management, there's an outpatient protocol that was developed and used for this study. SCM is based on the counseling model with a supportive approach, and it also ran for 18 months, weekly and individual group sessions. Participants were recruited from referrals for personality disorder treatment. Participants in this study were part of a larger pragmatic randomized superiority trial, and the design of this study was a subgroup analysis. There were 40 total participants, and you can see the breakdown here and the inclusion criteria. So they had to have a diagnosis of BPD and ASPD, a suicide attempt or episode of life-threatening harm within the last 6 months, and be between the ages of 18 and 65. Most participants were male, and the average age was around 30 to 31.5. So both groups had weekly sessions and had crisis contact and crisis plans set up, and they were also prescribed medication and had med reviews every 3 months. Outcomes were classified according to relation to aggression. So, anger, domineering relationships, hostility, paranoid ideation, and impulsivity were the target outcomes as indicators of problematic aggression. And then, anxiety, depression, and a summary indicator of psychiatric symptomatic distress were assessed as potential drivers of overt aggression. These are the measures that I listed here. I won't go through all of them, but these are the ones that were used. Some were modified just to have select items, and some were used in full. Overall, the results showed that the MBT group showed greater reductions in anger, hostility, and paranoia than the SCM group. At the end of treatment, fewer patients in the MBT group presented with impulse control related problems like suicidality and self harm, and frequency of suicide attempts and self harm was significantly lower in the MBT group at the end of treatment. Measures of negative mood and general psychiatric symptoms showed greater improvements in the MBT group. And at the end of treatment, the consequences of aggression, like poor general functioning, interpersonal problems, and issues with social adjustment, were improved in the MBT group as compared to those who received SCM. The authors did note limitations of the study, including that a longer-term follow-up is necessary to see if improvements are maintained, and a 5-year follow-up is underway. In terms of implications, the study highlights that MBT is a promising and necessary treatment for patients with BPD and ASPD. I thought, just like as a clinician, it's helpful to know that there is a treatment like MBT that can lead to significant improvements in many of the symptoms that this population experiences. In terms of connections to course content, I thought of 3 areas that we had talked about. Reading this article and its discussion of the mentalization model of antisocial behavior, I thought about the ethnotheories and specifically the attachment model that we had talked about during Module 2. The mentalization model of antisocial behavior is based on the idea that there was dysfunction of the attachment relationship early in life. My understanding of BPD is that it's very similar, that there are early attachment issues. So this is just kind of an observation that the attachment model seems to fit well with the development of both of these disorders, although of course there are other factors that contribute to development that are probably different for both disorders. It seems like the attachment issues is a similarity between them. Additionally, I thought about the sex differences that we talked about during Module 1. So there are sex-related diagnostic issues and differences in disruptive behavior disorders. And given that BPD is diagnosed more often in women and ASPD is diagnosed more often in men, and that the symptoms really do overlap quite a bit, I imagine that there's some misdiagnosis going on because clinicians are probably just more likely to give women a BPD diagnosis and men an ASPD diagnosis. So this just kind of made me curious about the true differences in sex between both of these disorders, and it's likely that more men have BPD than we know, and more women have ASPD than we know. I also thought about the Fonagy 2018 article where we learned that a limited capacity to mentalize may result in aggression. Again, I think this just highlights why improving mentalizing can be helpful in reducing aggression and other impulsive behaviors. And I thought this study that I'm talking about today relates well to that Fonagy study. In terms of connections to external content, I found a study by Wetterborg et al. It's a 2020 study, so very recently published. It was a clinical trial of DBT for men with BPD and antisocial behavior. I thought this article was really interesting because I'm just interested in BPD in general, and I've used DBT with clients. So this study was a study of 12 months of DBT, and 30 men participated. The results showed moderate to strong, statistically significant pre to post treatment reductions of self harm, verbal and physical aggression, and criminal offending. So, overall, the results were pretty promising. Symptoms of BPD were also substantially decreased, and the dropout rate was 30%, but participants who stayed in treatment reported high satisfaction with treatment and maintained their improvements at a 1-year follow-up. So I think, again, that's just nice as a clinician to see that there is another type of treatment that can be useful or beneficial for people who have BPD and antisocial behaviors. And here is my discussion question. Thank you.